Thank you. Good evening, and thank you for joining us tonight. The land on which UC Santa Cruz occupies is the unceded territory of the Awaswa-speaking Yupi tribe, Yamamutsun tribal band, comprised of the descendants of indigenous people taken to Mission Santa Cruz and San Juan Bautista during Spanish colonization of the Central Coast, is today working hard to restore traditional stewardship practices on these lands and heal from historical trauma. Before we begin this evening, I would like to share a few details about the event tonight. We are using a webinar tool, so there is no chat function. We will have an opportunity to answer your questions at the end of the program, and we invite you to submit your questions into the question and answer box at any time. Tonight's event will be recorded. Tonight, it is my great pleasure to introduce the book launch at UC Santa Cruz of Professor James Doucet-Battle's book, Sweetness in the Blood, Race, Risk, and Type 2 Diabetes. Sweetness in the Blood raises issues that long have been at the heart of our work here at Science and Justice Research Center. Most importantly, the limits of inclusion and diversity as frameworks for addressing deep-seated problems of justice and equity in the sciences and engineering. And I very much look forward to our discussions tonight. It is now my honor to introduce Nancy Chen, who is a professor of anthropology and associate dean for health, well-being, and society at the University of California, Santa Cruz. She is also the author and co-editor of many, many books, just a few I want to mention. Food, Medicine, and the Quest for Good Health, Bodies in the Making, Asian Biotech, Ethics and Communities of Fate. And Professor Chen will be moderating the discussion tonight. Welcome, Professor Chen.
Great, thank you so much, Professor Jenny Verdon. And it's my great pleasure to say a little bit more about this wonderful new book. In launching Sweetness in the Blood, Race, Risk, and Type 2 Diabetes, James Doucet-Battle, a medical anthropologist and assistant professor of sociology at UC Santa Cruz, takes up the important task of weaving together complex strands of theory, practice, and experience into a coherent narrative about type 2 diabetes, a seemingly simple disease to understand. Sweetness in the Blood takes the reader on an unexpected journey through contested definitions and ambiguous assemblages of race, recruitment, and risk in a critical examination of three distinct, successive, and interrelated technological moments between 2008 through 2012, and when causal explanations of type 2 diabetes changed radically. Now it's my great pleasure to introduce our distinguished conversants and speakers this evening. James Doucet-Battle is an assistant professor in the Department of Sociology at UC Santa Cruz. He is a graduate of the University of California, Berkeley, UC San Francisco Joint Medical Anthropology Program. His research and teaching interests lie at the intersection of science, technology, and society, and development studies and anthropological approaches to health and medicine. He applies these interests to study the political economy of genomic discourses about race, risk, and health disparities. And in conversation with him tonight will be Mr. Edward Hawthorne, who is the founder and managing partner of CE3 Solutions. He currently serves in at this place as the Chief Administrative Officer. And prior to CE3 Solutions, Mr. Hawthorne had a distinguished 33-year career with the Bank of America, holding various senior executive positions covering technology, operational risk, and customer servicing worldwide. He is currently Vice Chairman of the Board for the Diabetes Leadership Council and serves on the Emeritus Council for the American Diabetes Association, as well as the Board of Directors for Children with Diabetes. He is also the past chairman of the National Board of Directors for the American Diabetes Association. So I want to extend a warm welcome to both our distinguished conversants, speakers who will be in conversation. We'll begin with a reading from Professor Doucet-Battle, who will read a very short selection from this wonderful book, and then we'll commence with the conversation. Mr. Hawthorne will probably respond, and then we'll begin with several questions and possibly, hopefully, more of a conversation. So let me go ahead and turn it over to Professor Doucet-Battle.
Thank you, Professor Chen, for that wonderful introduction. And thank you all for joining us tonight for this conversation. I'd like to especially thank Mr. Edward Hawthorne for being so gracious in accepting the offer to come and discuss this book and to be part of this book launch. Really excited to be here. I'd like to begin, as mentioned, with an excerpt from the book. I take it from chapter 1, entitled The At-Risk Ethnographer of Sweetness. And to begin, I'd like to offer a quote from W.E.B. Du Bois from his work, Health and Physique of the Negro American, written just after the turn of the 20th century. And he wrote, "We might continue this argument almost indefinitely, going to one conclusion, that the Negro death rate and sickness are largely matters of condition and not due to racial traits and tendencies," unquote. In the summer of 2009, I met Darlene Pedraza. I use pseudonyms for all of my interlocutors. I met Darlene Pedraza at a diabetes education class in Livermore, California. Her boss, Betty Washington, a diabetes educator working with the Alameda County Department of Public Health, had connected us. Over that summer, I was fortunate to shadow Darlene in the field, conduct interviews, and attend her classes. An energetic and knowledgeable teacher, Darlene and her associate, Hector Elizondo, offered to test me for type 2 diabetes at our very first meeting. Now, as an anthropologist, I found myself caught rather off guard by the offer. Envisioning my initial involvement as more observation than participation, I was descended from a presumably objective stance of analyzing to that of being analyzed. However, subjectively, I began my project concerned about just how much the historical and genealogical legacies of sugar had manifested themselves biologically in my body. Membership in a high-risk group, academically induced corpulence, having had a diabetic grandmother and pre-diabetic mother, as well as the associated discourses of risk surrounding such pathological forms of racial kinship, swirled through my mind. So, deciding to face the facts with a mixture of curiosity and dread, I accepted the offer. "This won't take but a minute, James," Hector said as I presented my arm. "Just think, only a few years ago you would have had to go to the clinic to take this test. Using a portable hemoglobin A1C testing unit, field clinicians could then accurately measure the glucose metabolism of a red blood cell over the roughly 3 months of the cell's half-life. This gives greater diagnostic reliability over testing technologies. For example, a glucometer can only measure current blood sugar levels, although newer models can store weeks and months worth of data, which can be sent directly to the physician or the clinician's office. The finger prick was barely noticeable, hardly warranting mention. Having always been rather squeamish about needles and other invasive procedures, I was surprised at the relative absence of pain. Now for the result. Extracting not a vial, but what I could only call a smidgen of blood, the hemoglobin A1C device took perhaps a minute to analyze my blood sugar metabolism, or at the very least, how it had been behaving metabolically over the course of the last 3 months. During that time, I had uncontrollable visions of future performances of therapeutic contrition and penance, salads, bike rides, walking around Lake Merritt in Oakland every morning, yoga classes in Berkeley every evening, pilgrimages to farmers markets every weekend, and a gym membership for everything in between. 5.1, Hector announced as the number flashed across the device screen. Perfect. Instantaneous joy and relief competed for my attention. However, an uncertain confusion punctuated these initial sentiments. Had I averted the pathologies of kinship? Were the vagaries of race and the specifics of relatedness lingering in the deeper biological recesses of my genetic and genomic destiny, waiting to emerge, waiting to strike? In my case, a refusal to take the test carried its own risks against a larger backdrop of the stakes involved in conducting this research project. In terms of risk, refusal existed within a realm of predictive possibility that, due to my racial and familial histories, I could have missed the opportunity to definitively know about the state of my metabolic health. Yet regarding the stakes involved, my refusal could have also been seen as a personal protest against the predictive black box of racial determinism. Such a refusal would signal my rebellion against the racial categories that the book questions and seeks to make irrelevant regarding precisely which people develop type 2 diabetes and how they develop the illness. Much to W.E.B. Du Bois's certain chagrin, arguments linking racial traits and tendencies to disease have continued almost indefinitely, as he predicted. So in the following pages of the book, I interrogate race and risk as the primary but flawed technological drivers of type 2 diabetes biomedical research recruitment. I explore the role of race in the development of diabetes technologies that move the epidemiological clock backward in time, from diagnosis to risk prediction of the asymptomatic individual. I take particular interest in how diagnostic and now predictive assessment technologies have served to rationalize new pharmaceutical interventions and regimes of blood glucose control. So moving forward, I ask you to consider that the obesity and type 2 diabetes pandemics, which Meryl Singer would argue is termed as syndemic, that these arguably make moot any temptation to equate race with culture or nurture, or race with biology and nature. So my primary argument in this book and in this conversation this evening is that the framing of type 2 diabetes risk as racially differentiated in terms of biology misses the conceptual mark. That of type 2 diabetes as consequential of physiological affect in relation to consumption and to capital. And in doing so, it reflects new forms of behavior. Thank you.
I guess, well, Dr. Doucet-Battle, first of all, I want to thank you. I feel I'm honored that you invited me to participate in your book launch. And it's important for me, but also I was surprised because I'm neither a healthcare professional, a scientist, or an academic. I'm just a layperson. And I'm fortunate that neither myself or anyone in my immediate family have diabetes. But nonetheless, I, like all Americans, are impacted by the disease in one way or another, directly or indirectly. And I committed to join the fight to prevent, cure, and improve the lives of all people living with diabetes over 27 years ago. And my boss at the time, Marty Stein, assigned me to lead a corporate fundraiser for the American Diabetes Association. And I had never heard of the ADA, and it could have been any organization's name on the marquee, but it was the ADA. And that's when I began learning about diabetes and the prevalence of the disease around the world, but especially in the African American and people of color communities. And today I remain active today, and a lot of my friends ask me why. And simply put, I just say, because selfishly it feels good to do good for others, especially in eliminating health equities and improving health outcomes. But diabetes is a pervasive disease, and it's imperative that we act. And the question for me is always how and what. And I think in your book, Sweetness in the Blood, it's an eye-opening perspective on the disease, but it's overlaid with historical and current racial implications. To change, we must unravel the history, the social and economic issues that got us here and remain obstacles today. And I think the journey that your book takes us through today is not only a history lesson of race and diabetes, but is also a call to action.
Thank you. And I agree. And I appreciate those remarks. What I found, particularly from a historical perspective, is that 100 years ago in this country, African Americans were not seen as a high risk type 2 diabetes, or what they would call adult onset diabetes risk population. As I explore in the book, or as I explain in the book, 100 years ago, Jewish American immigrants, mainly from Eastern Europe, were seen as the model high risk type 2 diabetes group. And today, very little mention is made of that. Very little of that history remains in the institutional memory. But over the course of the 20th century, other groups became seen as high-risk type 2 diabetes groups, namely indigenous, Native American groups, Latinx, Latino populations, and toward the middle to late part of the 20th century, African Americans increasingly were seen as a type 2 diabetes risk group. So this history buttresses my argument in very significant ways that type 2 diabetes isn't necessarily something that could be reduced to causal factors attributable to race, but that it can, in a sense, or should be seen as environmentally determined. I have a section where I discuss what is known in genetics as the thrifty gene hypothesis, which was proffered in 1962 by geneticist James Neal, where he argued that type 2 diabetes tended to occur in populations that existed in the midst of excess calories, and that that there are populations that have what are known as a thrifty gene that have developed evolutionarily over time to allow us as humans, as Homo sapiens, to withstand feast or famine situations. But his argument was never a racial argument. It was an environmentally contingent argument. And over the course of the 20th century, or excuse me, the second half of the 20th century, his hypothesis became seen through a racial lens, and Native Americans became seen as, and those with Native American ancestry became seen as the prima facie examples of that particular type of diabetes risk. But as Arlene Tuckman discusses in her work, we don't, excuse me, not Arlene Tuckman, Carolyn Fee, Marjorie Fee, we don't really know when that hypothesis became racialized. But over time, racial arguments, racial claims, racial attributions to type 2 diabetes risk have not decreased, but they've actually increased over time.
When you talk about wrong body, wrong people, wrong places, how does that play into this notion that we don't know when it happened, but it feels as though if you're a person of color, minority, African American, that we've got the wrong bodies and we just got caught up in the wrong places?
That statement in the book was attributed to the ways in which transatlantic slavery, particularly sugar plantation slavery, brought together all of these disparate groups of people into new places, what Henry Hobhouse called a site where all of the wrong people from all of the wrong places were brought together, and in doing so created what we would call Creole societies. And my mother's side of the family coming from Southern Louisiana is one of those sites in the global, or at least in the hemispheric, transatlantic slave, sugar production, sugar plantation constellation, where this creolization, this bringing together of people from different places, yes, ostensibly for the creation of a sugar industry eventually, but also for the creation of a new society driven by global capital, and the ways in which over time sugar plantation slavery not only changed nutritional destinies in the global north, as Sidney Mintz argues in his work, but also changed nutritional and epidemiological destinies in the global south and among the formerly enslaved themselves. But once again, that contributes to my argument that this is historically and environmentally contingent, and that it's not racially or biologically contingent. We're finding in the society now, I just received some correspondence from my insurance company 3 days ago that says that 1 out of every 3 Americans is now considered pre-diabetic. So the argument that I'm making in the book is one for environment and against race.
It's interesting. You mentioned the pre-diabetics, and that's sort of an interesting. It's interesting for me because if you think about the population of diabetes, over 34 million people with diabetes, and then this notion of before we could not identify people that were pre-diabetic, correct? And so, but when you add that in there now, that's over 120 million people with diabetes or pre-diabetes. So when I think about that, I'm thinking about this notion of a cure versus care. If I can cure this disease, that's a one-time shot. But with diabetes continuing to grow at 1.5 million, cases a year, on top of that, the economics of it says that if I can find medicine that I can treat people with diabetes and keep them alive, I've got an ongoing revenue stream for a long time. So from a perspective of economics, right, diabetes is a pretty lucrative disease.
It's a very lucrative disease, and it commands a large proportion. Some estimates say that it commands a majority of the healthcare dollars spent in this country. The amount of money that people have to spend on not only devices, but also on insulin every year has gotten to the point where where we're reading reports of people who are actually cutting their doses of insulin in order to save money to be able to afford the other expenses that they need for living. So if a medicine could be created, the question is, what sort of medicine would that be? You said a one-shot medicine. That would almost define it as a vaccine.
Yeah.
But what makes it profitable today are the repeat users who continue to have to purchase and use insulin and metformin and other types of pharmaceuticals. And it's those repeat users, as one pharmaceutical executive mentioned to me, is what drives the market. So vaccines are not profitable to drug companies. With the latest pandemic, these particular vaccines, a way has been found to make them relatively profitable. But generally speaking, vaccines or one-shot medications, generally speaking, are not profitable.
You know, it's interesting because I always think about this being, I believe that this is the 100th year of the discovery of insulin.
Yes.
And so if you think about Banting and Bess, who had this discovery and had the sort of sense of care to say, this was so important to society that we're going to give away our patents for nothing. I believe they gave it to Eli Lilly because we want that discovery to benefit people with diabetes and have access to it. But today, you look at people, one of the biggest issues in health disparities in healthcare is that people don't have access to healthcare, which means they don't have access to this very medicine that this discovery that Banting and Bess wanted to make available to them. So I wonder what they'd be saying right now when they look at us today.
I share that sense of wonder with you. I think that the social and the economic climate has changed so much since 1921, 1923. The market drivers that legitimate the marketing of anti-diabetic drugs have changed. The amount of R&D that goes into creating them creates its own economic rationale. And we have to remember that since the discovery, since the discovery of insulin, it was such a revolutionary moment that we can easily forget how devastating the disease was until that, or before that time, particularly for type 1 diabetics who need insulin to live. That used to be called childhood or juvenile diabetes. So the nomenclature has changed, as you know. It's no longer juvenile diabetes, it's now type 1 diabetes. What used to be called adult onset diabetes is now known as type 2 diabetes. Type 1 diabetes can be contracted by people of any age. The best of scientific research now says that that is contracted primarily through a viral infection. Type 2 diabetes is different. It's amenable in many respects to dietary and lifestyle changes and increases in physical activity. And it's rather unfortunate that type 1 and type 2 diabetes are mentioned often in the same breath. But in terms of treatment, particularly for chronic type 2 diabetics, they too need insulin to live. So we have to keep in mind, I would strongly argue that the differences between the revolutionary appearance of insulin in 1921, 1923 came at a time in which people were really suffering from the disease. And there have been many advances in the technology. We just think about the width of the needles that were used to administer insulin compared to the needles that are used now. There's been so much progress, so many advances in the ways in which diabetes is treated and the ways in which diabetics are able to attend to their healthcare needs. But the cost.
Diabetes is a smart disease too. I mean, today, like you were talking about childhood diabetes and an adult onset, and so now you have adults with type 1, you have children with type 2 diabetes, you have the latter kind of diabetes that affects a lot of African Americans. It sometimes get misdiagnosed, the latent autoimmune diabetes in adults. But a statistic that I find interesting is that by the year 2050, type 1 diabetes is increasing by 23%. As it relates to this conversation, what's interesting is non-Hispanic whites, type 1 diabetes will decrease from about 80% today to about 50%. Non-Hispanic Blacks, Hispanics, Asian Pacifics, and Asian Pacific Islanders and Asians show the most significant increase in type 1 diabetes, and they're projected to have worse outcomes. So now you've got this issue affecting, minorities and people of color on type 1 diabetes, and you have it on type 2, and you have it growing in type 1. So I'm not sure what that means, except that the problem is just getting worse.
And as you mentioned, disparities in access to healthcare do not augur well for these increases among these populations.
Right.
And I think given those disparities in access to healthcare, I think we also need to keep in mind when we're speaking about pre-diabetics, we need to also remember the hidden diabetics, those people who have type 2 diabetes and are unaware that they actually have it.
Absolutely.
We have high levels of, we haven't talked about rates of limb amputations that occur among underrepresented minorities who get their diabetes treated too late or who aren't able to afford medications and are not able to take them in a timely and adequate way, and the worsening of those conditions over time. People that I worked with, many of them in the health professions tended to see type 2 diabetes as a progressively worsening disease, despite the fact that it is, once again, amenable to diet and lifestyle changes. But what they told me was that they're not necessarily treating these issues. They're treating the social context in which people live in.
Yeah.
And that is the biggest challenge that they face in their practices.
You know, one of the conversations I've had with Tracy Brown, the CEO of the American Diabetes Association, and when I chaired the board, was always around optics. So, you know, more people die from diabetes than AIDS and breast cancer all combined together, right? But when you saw a picture of someone with AIDS, you felt bad because they look bad. When you see someone with type 2 diabetes, they look good. So they don't look sick. So it doesn't pull on the heartstring. And so I've talked to parents who have children with type 2 diabetes, right? And one of the things they say is that, you know, the optics of it, right? So I can give optimism and hope by showing someone who looks good, living with diabetes, and saying, you too can have that life and look good. And do I want to show them with someone who's blind, you know, had a leg amputated and all of these things that say, you know, if you don't take care of yourself, this is what's going to happen to you. And the reality is, I think everyone has in the industry has gone towards let's show the optimistic point of view, but it also hurts because it doesn't allow people to see the seriousness of the disease and the complications and what they look like.
Yeah. Well, as Keith Wailu talks about in his book, Living and Dying in the City of the Blues, where he talks about the ways in which sickle cell anemia became increasingly visible in the African American community, and the forms of media and governmental exposure that were required to bring that about. I think type 2 diabetes is going to need a similar sort of PR project. I think as the current population of younger people get older, as more high profile entertainers and athletes and others develop the illness, perhaps they will help to construct a platform, a public platform for making the illness more visible. I think the other thing is that very few people, if any, actually die from diabetes. They tend to die either from kidney disease or heart disease or other illnesses such as that are to which type 2 diabetes worsens. So
yeah.
Pinpointing the cause of death is usually not attributed to diabetes. The death certificate will usually say kidney failure.
Yeah.
Or,
I mean, and it's so, and
yeah.
it's been talked about that death due to diabetes is definitely underreported today. And if it's the 7th leading cause of death and it's underreported, that means this is really one hell of a disease, right? I mean, you know, I'm not sure what to do there. And you're right. I mean, everything talks about sort of the underlying. Hopefully, we're getting more about the underlying cause of death, and diabetes is mentioned someplace, but it doesn't really call out that the death was caused by diabetes, and so therefore, you don't really see the true impact. But you know, your point about the visibility of the disease, and you know, I think later on in one of the themes you're talking about sort of outreach and things, and I think, you know, a really interesting point will be how you know, I hate to say market in terms of a word like that you use when you want to sell something, but you really have to market the community to get them to understand the seriousness of the disease and the things that they may can do today to, you know, prevent the worsening effects of that disease on them.
Well, one thing I can say from my research, and I talk about it in one of the chapters in the book, is that African American churches many of them are doing valiant work in their community to try to bring the message around type 2 diabetes, to bring education, to bring testing to their communities, particularly through their churches. They're holding diabetes classes, diabetes workshops. They're inviting speakers to come and present to interested members of the congregation. Many of these churches have what are called health ministries or health cabinets, and they do tremendous amount of work. The people who I worked with in the upstate New York portion of my work, they were actually members of the church, and they worked with they were members of the American Diabetes Association. They had contacts in the community. But one of the drawbacks, one of the limitations that I saw from using the church as a venue is that it only brought a certain demographic. It tended to bring people in over 40, 45 years of age, overwhelmingly women, and the younger population, the younger members of the community weren't a part of these efforts. They would actually drive their parents to the workshops and the meetings at the church and drop them off, and then drive away and then come and pick them up. And when it comes to prediabetes and diabetic risk, those are exactly the people who need to be brought in, who need to be tested, who need to be educated. So I think moving forward, and we're going to talk about ways forward in a little while, finding ways of reaching out to the younger population across ethnic and racial groups, I think is one of the challenges of diabetes outreach, not only in the present, but I think more importantly in the future.
James, I think that we'll have to get the industry society to stop thinking about the African American community as like one thing, one people. It's always like, just do this for the African American community and everything will be great. Well, not everyone goes to church, like you said. Not everyone feels the same. And even within that church, not everyone has the same issues, right? You've got some people, they have great access to healthcare and they're affluent. You got others who don't. So there's that combination of issues. So that this point about it isn't as simple as going to a Black church. It is the message that you send to the different constituents within that church who have a different need.
Yeah. So the institutional imagination needs to find ways of moving beyond the church.
Yes.
So the question is where to find these young people, where to engage them. And I think underlying all of this are questions of trust, social trust, trust in the society, trust in institutions and in organizations to actually care. And as I've discussed elsewhere, the African American community, the younger population as well as the older population have been through a lot in the last 40 or 50 years. They've gone through mass incarceration. They've experienced a cocaine epidemic that has eviscerated many inner cities and communities in this country. And the HIV/AIDS epidemic also caused a tremendous amount of produced effects that are still being dealt with today. And we have the phenomena of lethal policing that many young people are quite aware of and quite conscious of. So this backdrop of trauma and punishment, it's very difficult, I would argue, and people I've interviewed have also mentioned. And I think we're seeing this with the pandemic and reticence to accept the vaccine, is that all of a sudden this declaration of care is being extended to these communities. And there are some people, or there are some communities that are not entirely convinced that the care is really there. And I think, and I argue in the book, medical justice and social justice are inextricably linked. And to the extent that one is missing, it'll be very difficult to achieve the other. But it needs to occur, it needs to happen. And without that, I think efforts to address type 2 diabetes within the community face an uphill challenge.
Yeah, I mean, because the care is there. I think the bigger issue is the trust, right? I mean, and partly, these communities, the community doesn't see enough people that look like them, enough people that have experienced the same things that they do, enough people who have the same reservations around trust that they have. And so whether you look about how many endocrinologists do we have and primary care physicians do we have and all those things that look like and can relate to the community, it's going to be difficult, right? Because of the history of it all, right? So how do you just walk and say, okay, we've changed and everything else still looks very white, and you say we've changed, but nothing for this community looks different. They still don't see anyone that looks like them or enough people that look like them, and say that there are enough people in those parts of the organization, in science, in the pharmaceutical companies who are thinking about me and my well-being that generates more trust.
And that's why pharmaceutical companies, research institutions, clinical recruitment firms, public health organizations have been trying to ramp up their diversity hiring efforts and to bring in more people of color into their organizations. And the people who I interviewed, people of color in various organizations, they actually feel and think that it's their ethical responsibility to be in these positions for exactly the reasons that you mentioned, that they have an ethical challenge, and that if they weren't there, not only would the outreach and recruitment be less successful, but that without their presence, a certain safeguarding, a certain ensuring of an ethical approach toward these populations, a culturally competent approach toward these populations would remain elusive.
Well, like some of the pharmaceutical companies, I mean, I would contend are sort of treating at the symptoms and not at the root cause, which is I'm trying to hire more people in my organization. But the reality is, if you trace back, where should they be starting? Are kids graduating from high school? Are we sort of providing mentors in those communities? Are we providing mentors as they go through college? Are we getting people to understand? So they're folks on one end, but the question is, are they pulling it all the way through to the beginning, right? That's where you've got to get started. If ultimately you want to have an impact on the diversity of people in those fields, you have to start much, much sooner.
And much sooner than high school.
Yeah.
And I think that given these disparities, it's easy to talk about health disparities, but there's a constellation of social disparities and educational disparities. Medical literacy relies on basic literacy. It's a cumulative process of growth and development. So while it's easy to have a myopic gaze on the health disparities and addressing health disparities, there are the educational disparities that need to first be addressed, that also need to be addressed in order to educate new cohorts of students of color who are able and prepared to get through medical school. So you may know, Xavier University in New Orleans has a wonderful program, a pre-med program of preparing African-American, African descent students for medical school. And they have an extremely high rate of successful placements into medical school programs. And the ways in which they support and guide and build an academic file on students beginning in their freshman year at Xavier, leading all the way to their application to graduate school. They are placing more students into medical school programs than many of the top elite, predominantly white institutions in this country. So that sort of nurturing and development of the academic and the professional potential in students of color is something that not only needs more funding, more support, but it also needs more organizational structure and guidance in ways in which the Xavier model has been so successful in achieving.
And fundamentally, too, it also helps. I mean, you were talking about the educational disparities that exist, but that model starting at low helps in a number of different fronts, because that leads also to the healthcare inequities. And a big reason why that exists is because there's not sufficient insurance literacy. So if you don't understand your insurance, you can't get the care that you need. And that's a big issue. So we got to think about sort of, as we're talking about this, which is getting people to be literate around insurance, because that's the key to getting them access to healthcare. There's a big issue about availability of it all, but if it's available and you have access to it and you don't understand how to use it, that's still a problem.
Indeed. And given the expense of simply being a type 2 diabetic, it's one thing to go out and want to test more and more people. But what happens once you test someone from an underserved population and all of a sudden they have a positive diagnosis, but they have no insurance?
That's right.
What are they going to do?
Yeah. I mean, there's been so many deaths by people trying to share their medication, half their medication, not take it like they should, just because they can't afford it. I mean, in the United States today, in 2021, people don't have access to life-saving medicine. I mean, it's just a shame.
So we have other ways. We have other options that seem plausible. One is diet, lifestyle change. All diabetics, whether type 1 or type 2, need to engage in high levels of aerobic activity. As I discuss in the book, the American Heart Association and the American Diabetes Association, two organizations that have clashed, for lack of a better term, over the years, finally agreed on aerobic exercise or physical activity. We don't use the word exercise anymore, which I think is quite telling. We use the term physical activity now. The appropriate and recommended levels of physical activity for type 2 diabetics, or for diabetics in general, which is about between 140 and 180 minutes per week. But given the social context that many people are living in, the aesthetics of environment, the access to nature, to the outdoors, the safety of being outdoors, various issues around even climate. I remember interviewing a diabetic in Houston, Texas, who was saying in the summer, if I don't get outside before 4:30 or 5 o'clock in the morning, it's just simply too hot to go out and walk around the block, to walk around my neighborhood. Whereas in upstate New York, people tend to have 4 or 5 good months for being outside, but for the rest of the winter, their physical activity in terms of being outdoors is quite constrained. So this is where gyms come in, but not everyone can afford a gym membership. And the pandemic has completely, I think, changed many Americans, and let's just say many global citizens' relationship with physical activity, with movement. We've gone through lockdowns, we've gone through quarantines, we've gone through shelter in place. I'm working on a project now, working on a proposal with Nancy Chen and a community partner on the ways in which type 2 diabetes has, and type 2 diabetics have coped with the illness since the beginning of the pandemic. And what does that mean for them? And what has it meant for them in terms of physical activity and being able to get out, to being able to move? There's been a phenomena that people euphemistically call the quarantine 15, where as a result of many of us sitting at home more than we'd like to, spending many hours behind the screen, for example, that a good number of people have said that they've gained a good bit of weight. And the quarantine 15, I think, is quite telling, because we know in terms of type 2 diabetes, those 10 to 15 pounds can make a big difference in terms of one's in terms of one's hemoglobin A1C reading or a measurement. So we've seen people rebelling against shelter in place, people wanting to go out, wanting to move. And on one level, that's understandable, but from a viral infectious standpoint, it's not advisable. And I think moving forward, it remains to be seen what effects the pandemic will have on American society in terms of movement, in terms of the way we eat. The ways in which we shop for groceries for many of us has changed. People have been ordering out more often, getting Grubhub and DoorDash and so on and so forth. So the ways in which we relate to food, the ways in which we relate to movement, the ways in which we relate to each other, I think are going to warrant a significant amount of research and examination over the next several years.
Dave, I have a question because, you know, at one point I think I've had the conversation with lots of people as well that says, you know, diet and exercise, all good for type 2 diabetes. But if you look at, you know, telling people, you know, stop watching, you know, your TV, get off, stop eating all those sugary foods. But if you, I would assume that there are as many white people who are sedentary, eat the wrong stuff, live in bad neighborhoods, yet the Black community is disproportionately impacted by diabetes when they have the same habits. Why is that?
I think if we go by the statistics, apparently 1 out of every 2 African American adults is considered clinically overweight. 38% of white Americans are considered clinically overweight. But I think when we look at the statistics more closely and break it down, we find that when we parse it out according to socioeconomic status, higher income whites tend to have lower body mass indexes, and lower income whites tend to have higher body mass indexes. And because African Americans tend to be less economically well off than white Americans, socioeconomic status goes a long way to explaining the discrepancies between white Americans and African Americans.
Thank you.
And Latino Americans as well.
So I want to thank you both for this amazing conversation, and maybe this might be an opportunity. You've mentioned a little bit about the pandemic, and I'm wondering with this vaccination rollout, particularly, you know, the lessons learned regarding vulnerability, and especially for diabetics or pre-diabetics, how might potential outcomes might be different if there's community engagement and outreach?
Great question. For me, I think it's about the methods and the modes of outreach, how to go about it, because I know of an African American researcher in Atlanta who's been charged with conducting outreach toward African Americans around the vaccine. And she's finding it extremely difficult. We have a situation where, according to a survey that I read 2 weeks ago, fully 3/4 of African American health professionals surveyed said that they will not receive the vaccine. So when we look at this from the lens of education and outreach, I think sometimes education and even socioeconomic status can only take us so far in our analysis. That there are significant numbers of African Americans who actually work in healthcare who are quite apprehensive about receiving the vaccine.
You know, I would say, James, you know Dr. Gary Puckering from the National Minority Equality Forum. And a quote from him, he says, "The outward manifestations of segregations have been removed, but the inequities have not. And the pandemic has just opened it all up." And if you think about just bring it closer to home in just California. California's minority communities are disproportionately impacted by the coronavirus. And the early state statistics are reporting that COVID-19 fatalities are double their percentage of the general population. And so I equate that to what I call the 3 A's: availability, access, and affordability to healthcare.
I agree. And that's why I recommend, and I definitely urge members of the audience to participate in whatever way possible in terms of volunteering with the ADA, community organizations. Yes, if you do belong to a religious organization that has medical outreach or diabetes outreach or is doing diabetes outreach work, please take part, contribute to the effort. I spoke to a pastor in a congregation here in Oakland whose church did not have a health ministry. And I asked them, would they consider starting a health ministry, particularly around type 2 diabetes? And they told me, quote, "I follow the footsteps, I don't lead. So unless the congregation steps forward and urges that we endeavor to make a stand, to contribute to this particular issue, I don't step in and try to lead on my own. So the congregation has to lead. Otherwise, and this is what Du Bois says about the African American church, that the pastors lead from behind and not the front of the congregation. And that goes all the way back to Martin Luther King's time and the ways in which his ministry and his work on civil rights was in many quarters of the African American church not readily accepted initially. So, so yes, I definitely urge those of you in the audience to take part. The ADA has diabetes walks. It has bike events for raising money for type 2 diabetes. Talk to your family and just get involved. It's everything from infrastructure projects in your communities, making sure that open spaces are preserved. These are longer term projects. But I think in terms of the aesthetic environment necessary for encouraging all of us to go out more, to be out more, and to socialize more. So when we're talking about inclusion and we're talking about participation, these aren't just institutional or organizational objectives. These are social objectives. And I think in terms of access and affordability and the ways in which these are experienced differentially between groups, I think that the more that the spatial and social and political borders and boundaries that keep us apart from each other persist, we're going to continue to have these disparities in health and health outcomes.
And James, I'll share a couple things from 2 organizations I'm involved with, because I think you're absolutely right. I mean, people with diabetes, personal circumstances vary. There's no one size fit all. There's no shortcuts. And, today it's so unfortunate that people who are living with diabetes make unimaginable choices as it relates just to their care. So one of the organizations, the Diabetes Leadership Council, in November of 2020, brought together 12 independent nonprofit national diabetes organization. And we created something called the Consensus Statement on the US Healthcare Reform for People with Diabetes. And the intent was to articulate for policymakers and healthcare system stakeholders how the nation's complicated healthcare and coverage system works for and sometimes against people with diabetes, and provide some tangible ideas for improvements. Some of the issues that they covered were really around access to medicine, access to technology and supplies, because African Americans are low on the adoption rate for medical devices, diabetes devices that you know, access to care, resources to access to type 2 diabetes onset prevention, and then dealing with the burden of living with diabetes, both from the quality of life and the psychosocial outcomes. What's interesting is the American Diabetes Association created something that they call the Health Equity Bill of Rights. And this begins to talk about some of the complications, right? Some of the complexities, right? Similar words said differently. I'm diabetic, which one am I gonna look at? But the American Diabetes Association, the good thing is that we're all covering the same issues. Theirs focus on the right to access insulin and other drugs affordably, the right to healthy food, the right to insurance that covers diabetes management and future cures, the right not to face stigma and discrimination, the right to avoid preventable amputations, the right to participate in clinical trials without fear, the right to stop prediabetes from becoming diabetes, the right to a built environment that does not raise the risk of getting diabetes, and the right to the latest medical advances, and the right to have your voices heard. So all of these are really good and they all make sense. But the challenge is, now that I have the right, how do I exercise it?
Like voting in Georgia.
Right, exactly.
Yes.
Exactly. And so that becomes, you know, the part that's difficult and challenging. And I think, you know, I think about like the diabetes ecosystem, right? And that's what, if you're a person with diabetes, you're sitting in the center of this thing. And outside, you've got all of your healthcare professionals, families, and communities. And then the next ring is all your medical research and public and nonprofit organizations. And then on that other layer, you've got American Diabetes Association, policymakers, funders, payers, academic and medical professors, pharmaceutical. You got a wealth of people. So there's a million pieces to this system that makes it complex. One of the things I wanted to ask you to do was, there was a chapter on page 150 in your book that to me kind of get at the heart of the complexity of what we're trying to deal with as it relates to diabetes. And if you would read that for us, I think that would be good, because if you're a person with diabetes and you look at this ecosystem conversation I just had and you listen to that part of your book, I think the listeners here will get a sense of the complexity of what we're dealing with. And if you're a person with diabetes, how complex it is, not just managing your disease, but understanding everything that surrounds it.
I'll read it really quickly, and then I think we're going to have to quickly go to questions.
Okay.
So on page 150 in the book, I write, diagnostic technologies claim to speak for what the organ can and cannot do, or rather, what has happened to the organ, in our case, the pancreas. Glucometers purport to speak for what the organ is doing or has done recently. Diabetes risk scores claim to speak for a pancreas that has not yet contemplated pathological action. But public health understandings and outreach efforts speak using translated interpretations of a racialized pancreas recruited and indexed by risk. And pharmaceuticals claim that they can make the organ speak the true and authentic language of functional normalcy and rational efficiency. So yeah, when you mentioned families and organizations and public health languages and clinical research concerns, we're talking about 4 or 5 different cultures in search of a common language that can be communicated in dialogue across a terrain, a topography of trust that still needs to be developed. And that's what I'm addressing, and that's what I'm engaging and exploring in the book. Thank you so much. I'm ready to take your questions.
Great. And I want to thank both James and Edward for their incredible conversation. It was so engaging. It's hard to break away, but we're at the point where we've invited members of the audience to submit their questions in the Q&A. And so we won't be able to get to all of them, but hopefully several of them. And so one of the first questions actually is very nice segue into what you just said with regard to the complexity. This audience member says, an unfortunate circumstance is that many people watch relatives with diabetes try to live normal lives. Compound insurance inequities, healthcare access, lack of education, lifestyle, economic barriers, and access all feed into successful outcomes. Are there organizations that address a majority of these issues rather than one of them? And I guess this question could go to either of you, given the wealth of knowledge that both of you have.
Well, I mean, I'll start. I will say that I believe that there's no one size fits all, and I'm not certain if there's the closest organization I would say is that will address most of the concerns would be the American Diabetes Association, because they're focusing on. It's interesting about their mission because they're focusing on to prevent and to cure diabetes and improve the lives of all people living with diabetes. And there's a wealth of information and support and knowledge both on not only on care, but also on treatment. So, and education in terms of how to live with the disease and how to manage it.
And I would quickly add in agreement that the ADA offers a big tent that allows for a lot of different interests, a lot of different organizations, a lot of different specialties and medical subspecialties to get involved. One thing I heard a lot in the field was that when it comes, say, to general practitioners, people who have a general practitioner who they've known for a long time, sometimes the relationship gets to be a little too buddy-buddy. There'll be jokes about how much weight someone's gained, and less aggressive action would be taken around perhaps getting the patient to consider what's happening metabolically over time. On the other hand, physicians who I've talked to, not physicians I've talked to, people in the physical activity community say that when it comes to physical activity, really it's the people in the physical activity community who tend to walk the walk, and that people in the medical community tend to give it lip service. Or you have people in the medical community who are very type A. They've been successful with most things that they do. They're type A people. They get up at 4 in the morning. They exercise. They run around the lake. They do all of these things. And they have a hard time understanding why their patients can't do the same. Completely different objectives, completely different backgrounds, completely different ways of being in the world. So yes, the ADA really is the one-stop shop, for lack of a better term. It really is the big tent that allows for a lot of these conversations. Yeah.
And the good thing is that it connects with so many of the smaller organizations and specialties, like for diabetes, the Academy of Nutrition and Dietetics. I mean, so the ADA has a connection to all of those organizations, especially around care.
Great. We have another question from a member of the audience. Besides African American communities, indigenous communities in North America have also been gravely affected by diabetes, obesity, and other chronic diseases. I wonder if you can say something about how the possible passage of the universal healthcare program promoted by Congresswoman Alexandra Ocasio-Cortez, Congressman Bernie Sanders, and progressive grassroots organizations may possibly help reduce the chronic ailments suffered by people of color, the poor, migrants, and other marginalized communities in North America.
I would say that that proposed legislation, if enacted, would help to go a long way to address many of the gaps in treatment and in access that currently exist today. And in terms of Indigenous and Native American communities, I think we need to be even more vigilant because I think in the public's mind, Native Americans are relatively invisible. They're living in remote places, even though they live in the midst of our societies with all of us in urban and rural contexts. I devote a section to the book that's entitled The Emergence of the At-Risk Native American Diabetic. And it charts the ways in which historical factors such as dispossession, the introduction of a devitalized diet that created a certain dependency relationship on certain foodstuffs, created a situation that that formed the perfect storm for metabolic disorders, and the ways in which one tribe in particular, the Havasupai in the Grand Canyon, have been researched perhaps more than any other group in the world, and how that caused problems, particularly bioethical problems with or caused by researchers who appropriated some of their genetic material, some of their blood samples, and used them for purposes that were not outlined in the IRB.
And James, you know that speaking of legislation, there were lots of gains for all people with diabetes under the Patient Protection and Affordable Care Act. And so for people who are concerned about this issue, I mean, it has two folds, right? When you roll back this legislation, it has a huge negative impact on people with diabetes. And you say, how can I help? Get involved with things like DPAC, the Diabetes Patient Advocacy Coalition, or the DLC, who are advocating and trying to push legislation to not only sustain the benefits for people with diabetes in this legislation, but prevent the rollback and to actually move it forward. And so those are ways that you can help. So it's really not just about, can I go out and find out about diabetes, but what can I do to make sure that things that are being passed in Congress, that they aren't negatively impacting people with diabetes. And Professor Chen, that affects everybody and every ethnicity dealing with this disease.
Indeed.
Thank you so much. We have time for possibly one or two more questions. Another audience member is asking, how do you distinguish between environment and culture in your interrogation of the causes/influences of type 2 diabetes? And a subset or follow-up question is, as in, how do you keep from falling into the trap of biologizing race through culture?
Well, great questions. I'll take the last one first. In the book, I make it very clear early on that as an anthropologist, I do not subscribe with assertions that there is anything that could be termed a racial biology. So I delink race from biology in order to argue for an environmental contingency that can help, or that can foster diabetes occurrences, diabetes risk. And I think in terms of environment, I think there's been a lot of work on food deserts and food apartheid, and the ways in which access to healthy food is disproportionately unavailable for groups of color, and the increasing affordability of fast food and other forms of processed food make it much easier for people to develop metabolic disorders, excuse me. And that is definitely an environmental factor. And because people of a particular group are experiencing these forms of nutritional apartheid, much like Native American and indigenous communities, for example, it becomes easy to then assume that there's some sort of racial biology at work here. And I think that is where we make the fundamental mistake. And the first part of the question, excuse me?
Hold on, I had to scroll to back. How do you distinguish between environment and culture in your interrogation of the causes/influences of type 2 diabetes?
I think I'll answer this very quickly. I think it's very easy to associate the ways in which cultural practices that are occurring within a particular community space can be interpreted as cultural, but they're not really cultural. They are, in a sense, orchestrated, right? And because certain people who look a certain way are actually engaging in these forms of consumption, of relating, of being together, it becomes very easy to then think that that this is something cultural when it's really an environmentally determined situation.
Right. And there's another question from the audience. I actually think I can fit two more. This might be directed to Edward, where are there policy suggestions that could help mitigate the disproportionate harm of diabetes on BIPOC communities? And actually, both of you could, I think this is well directed to both of you.
Well, I mean, I'm not certain of a specific policy issue, because I think as James sort of alluded to, when you think about inequities, it's not just health, and it rolls back through all of the racial, inequities that are happening. We've got, so the issue is broad. I don't think that I can think of a single policy, but I think about sort of the whole notion of inequities today, and the things that are built into all of our systems, both politically, medically, scientifically, and all those things, and they all have to be addressed. And this makes the problem that we have, I think, so complex, because there isn't just one thing. So James, if you want to add to that.
I think in the interest of time, I'll leave it there, and maybe we can take one more question.
Yes, and this is a wonderful question that is, let me see if I can find it now. Thank you for this wonderful forum. And I wondered if you could tell us more about the title of the book, and if you can tell us a little bit more about the histories that help us understand how diabetes has become racialized in the ways that it has.
Great question. Well, as I mentioned, the book began as an autobiographical exploration, reflection into my membership in an at-risk group with a maternal background, family background, deep in the sugarcane fields of Louisiana, and having had a diabetic grandmother. I really wanted to understand the ways in which sugar served not only as a historical artifact, but as a metaphor for type 2 diabetes. So I dove deeply into the history of diabetes, the history of sugar, and tried to make sense of the ways in which the metabolic modernity or post-modernity that we occupy has come to be. So in terms of that particular history, I wanted to also understand how African Americans came, or African descent populations have come to occupy not a central, but a desirable place in type 2 diabetes research recruitment. So in one of the chapters, I look at the ways in which a diabetes risk study offshored its research to Mauritius, because the researchers thought that their rather homogeneous Scandinavian population was rather unconvincing in terms of its research results and claims. So they offloaded the research to a former sugar colony, an Afro-South Asian sugar colony, former French sugar colony in the Indian Ocean. And the company that I tracked here in Silicon Valley, who was also developing a diabetes risk instrument, had been relying on that Scandinavian data, and they too felt that that data was too homogeneous to make broader, more conclusive claims about the accuracy of the risk instrument. And they sought to attract African Americans into their research platform to test the precision and the accuracy of that particular technology. Then in another chapter, I look at the ways in which the diabetes research gaze moved forward toward genomics, and how after 2011, it became much more affordable to sequence a genome. And this takes us to the story of Henrietta Lacks, her mitochondrial DNA, and the ways in which the mapping of the genome and epigenome of the HeLa cell in 2013 promised to provide new explanations around metabolic adaptation to environmental change. So the possible ramifications of that research augured new possibilities for understanding the mechanisms behind type 2 diabetes. So through the HeLa cell, I was able, and I attempted to draw this historical, or to thread historically, the ways in which African descent labor continues to inform understandings around race, around risk, and metabolic adaptation in the form of type 2 diabetes. So that is why the book carries the title, Sweetness in the Blood, Race, Risk, and Type 2 Diabetes.
Thank you so much for that very eloquent explanation. And before I pass the baton, pass the mic back to Professor Jenny Reardon, I want to ask Mr. Hawthorne, Edward, if you had any closing remarks that you would like to say before we pass it on to the official closing remarks of this event.
Okay. You know, I do. I would say that with over 122 Americans living with diabetes or pre-diabetes, and as mentioned, 1.5 million being diagnosed every year with the disease, and the disease is nearly twice as common among communities of color, it is imperative that we act. And I think that James's book, Sweetness in the Blood, is a persuasive perspective on the disease, overlaid with historical and current racial consequences, and it proves that diabetes is complex. It's a multifaceted illness that requires an equally multifaceted solution, or solutions, that deal with health, healthcare, social and psychological issues, economic and political challenges, and most of all, the unaffordable acknowledgement of race.
So I want to thank Mr. Edward Hawthorne for your wonderful contributions and insights for this conversation, and also to Professor James Doucet-Battle for being present to help celebrate the new book. We're just really excited, and I'm going to pass the mic now to Professor Jenny Reardon, who has some closing remarks. So thank you so much to you both for that wonderful conversation.
Thank you.
Yeah, thank you, Edward and James. That I had the privilege of just being able to sit and listen to what was a very, very rich conversation. I think that you made very evident how important diabetes is as a disease, and gave us lots of ways to think about what we could do to address it. I want to highlight a few of those things as we go away tonight, thinking about what we might do. First of all, we might read the book, because I hopefully that you all have gotten a sense of just how rich this book is. It's also an incredible read. It's really engaging. James, I was noting earlier when I think you left the screen for earlier before our pre-meeting, the intro is just really evocative. The story you tell about your family and your first encounter with the sugar cubes, so I really encourage, first of all, for everyone to read the book. There is so much in here, so much richness here that takes you through the histories of race, diasporic experiences, as well as the history of the treatment of this disease. But there are a few things that I want to just call out from the conversation too. The important points that I think is worth reiterating is what Professor Doucet-Battle had to say about the importance of creating a trustworthy society, to have institutions that actually care. And I would charge us all to orient ourselves around that project of care and building institutions of care, because we can put all the information out there that, all kinds of rich information out there, but if people don't feel that they are being cared for by the institutions that are providing them with healthcare, in particular, we're not going to end this disease, nor are we going to end the pandemic. So I think also that also relates to what you had to say, James, about the methods and modes of outreach. It's not enough to do community engagement. It's how we do it. And you provide details about that in the book, which I think is one of its richest points. We talk so much about cultural competence and the need for that, but without really creating trust in communities, again, that's a key part of creating trustworthy, creating effective engagement and trustworthy institution. And your most powerful point about the importance of looking at the spatial, social, and political barriers that we need to tear down in order for us to create not just health justice or social justice. Both need each other, and to do that, we have to tear down these barriers. And race is something that puts up the barriers and keeps us from doing the intersectional work that I think you highlighted, both you and Edward highlighted, the need to work across, to not see this as a particularly African-American disease. And I think this is something that, is a challenge for all institutions that deal with addressing diabetes, is how to do that intersectional work. How to change the face of the disease. Edward, you talked a lot about the importance of what is visible, and how do we create the community we need to address diabetes. And you gave us so many ways to get involved, and I just want to amplify that. And I think this will be recorded. Our conversation will be recorded. For those of you who didn't quite take down all your notes during it, you'll be able to get access to it later on. But for now, I just want to say thank you again to both Edward Hawthorne and James Doucet-Battle for what was a very, very rich conversation tonight, and wish you all a good evening.
Thank you.
Thank you.